My name is Darren Highland. I'm the principal investigator on the effort trial. So I've got just sort of the summary slide of the overall trial where we aim to enroll 4,000 nutritionally high-risk patients to a prescription of a higher dose, 2.2 grams per kilogram per day, versus perhaps what we construe as usual care, which is around 1.2 or less grams per kilogram per day. And we follow patients for 60 days to evaluate their outcome with respect to mortality and time to discharge alive, which is a composite of both being alive and being discharged. Obviously, being discharged early alive would be a better outcome. I want to acknowledge that this is a pragmatic, volunteer, registry-based randomized controlled trial. A registry in the context that it really emerges from our International Nutrition Survey, volunteer-driven in the sense that there's no fees, but that you as a community are rallying without that remuneration financially, but rather within the context of your usual clinical practice as you're evaluating, doing your assessment, doing your prescription. We're constraining you to be randomized to that higher versus usual care dose. And then obviously you're collecting a lot of data to support that, which is awesome. To date, we have almost 350 patients randomized. So we've activated, I think, over 40 sites around the world. Danny's been the first site activated in the UK last week. And so we're really in early stages, but it's great to have all the UK sites on board. I've already articulated the research question: what is the effect of this higher versus usual care dose on 60-day mortality? I want to stress at this point the absolute necessity that practitioners involved in this trial have what we call equipoise, or this uncertainty as to what is the right dose of protein for critically ill patients. I imagine that you as dietitians or as participants on the call have that kind of uncertainty. Otherwise, you wouldn't have signed up to participate in the trial. But there may be strong beliefs by some of your clinical colleagues that, oh, high dose protein is harmful. Haven't you read this report? Or, oh, high dose protein is helpful. Haven't you read this report? And so we've tried to summarize all that literature, both in a nibble, that's a nutrition information bite posted on our website, and I'm just showing you sort of the lead paragraph of that nibble. And we also kind of sort of recommend that you distribute that nibble around your clinical units so that bedside nurses, attending physicians, and your other dietitian colleagues are all on the same page with respect to, hey, there's conflicting signals in the literature. We need to sort this out as to which is the best dose. I'll come back to this point later in the presentation, but we find this one of the big barriers to enrolling patients in participating ICUs is that lack of equipoise, that strong held belief that, oh no, this kind of patient needs either a high or low protein dose, as the case may be. So the intervention is only being randomized to a different prescription. All right, if the patient is randomized to the high group, you as clinicians are prescribing 2.2 or more. And if they're randomized to the usual group, then it's 1.2 or less grams per kilogram per day. And that's based on a body weight that should have been measured or estimated pre-ICU. We refer to that as sort of a dry weight. You know how ICU patients get a lot of fluids in their resuscitation. And so probably this is consistent with your clinical routine, that you're not actually using the weight in the bed on that day when you see them, but rather trying to figure out what they weighed when they were well before all 10 liters of fluid were given to them. We ask you to use their ideal body weight if their BMI is greater than 30, ideal body weight based on a BMI of optimal of 25. And we don't really prescribe how you achieve those targets, rather than to encourage you to achieve at least 80% of that which you prescribe. So if you're in the 1.2 group, you're trying to get at least to 1. If you're in the 2.2 group, you're trying to get at least 1.8. Of course, you can get more than 80%, but we don't want you to fall short of that quality metric of at least 80% of the prescription. And to be careful not to overfeed with energy in attempts to provide that high dose protein. The energy prescription should be the same between the two groups. And I won't go through the details on this slide. I'll just reference the ASPEN or SCCM guidelines that have recommendations for caloric intake on both non-obese and obese patients. And so whilst we're not protocolizing this, we are strongly endorsing it and suggesting that you're obviously going to be conscious of that energy prescription and not overfeed energy in an attempt to meet the higher protein intake. As I said a minute ago, we don't protocolize how you achieve that high protein intake. And that's probably what this is, a pragmatic, practice-based trial. We would understand that you would have tools available to you in your unit, tools, products, feeding protocols, etc., and that you'll be able to achieve at least 80% in both groups. Obviously, it's the high group that we are most concerned about. And in the first year of this trial, we've observed some sites struggle to achieve 80% of 2.2 grams per kilogram. And so I do want to just sort of briefly review some best practice ideas on how to achieve that 2.2 in the high group. And so I'll review these elements on the slide here quickly, but let me just also acknowledge that we produced a YouTube video. Actually, it's just a taped presentation, much like this presentation is taped, on a little more detail on how to optimally deliver, high dose enteral nutrition, high dose protein. So as a reference for you, you can go to our YouTube channel and watch that on a Friday night when you have nothing else to do. So let me just start by making a brief reference to the PEP-UP protocol, which most importantly takes a volume-based approach, not a rate-based approach. And I know there's been some interest in the UK with volume-based feedings, and so we would strongly endorse. Again, we're not protocolizing this, we're just endorsing it and recommending it to you as a part of how optimally to deliver enteral nutrition. Volume-based feeding protocols plus empiric use of protein supplements started early, plus or minus motility agents. Some sites, some physicians at some sites are reticent to start empiric motility agents, and so that's not necessarily a deal breaker. But if you want to use that preemptively for the first couple of days to cover them during their peak incidence of enteral feeding intolerance, which usually happens around day 3, that's kind of why we designed the PEP-UP protocol as is. And then obviously pushing the gastric residual volume threshold as high as possible to optimize nutrition delivery as well. So those are the components of the PEP-UP protocol. I refer you to our website and our publications if you want more information. I do draw your attention to the fact that we've created a whole suite of tools that should enable you to easily, well, not easily, it's still a bit of work to change a feeding protocol, but we've made the work of creating those tools and educational tools easier for you by posting them on the website. I make reference to this work by Arthur von Zanten using a high protein containing enteral formula. Now again, we're not providing any formulas, but if you have access to these kinds of formulas, these and other products like it made by other companies are going to be excellent for achieving those high protein goals. Regardless what formula you use, probably even if you use a high protein enteral solution, you're going to need enteral protein supplements to accomplish the 2.2 grams per kilogram per day. And I highlight this work by Grant O'Keefe, who sort of empirically started them on a enteral nutrition formula and dosed 1.5 grams per kilogram per day in divided doses of a protein supplement. And you can see in the slide that each of those strategies alone got around 1 gram per kilogram per day in, and then when you combine that, by day 3, patients are up in that 2.2 grams per kilogram per day. So the aggressive early empiric use protein supplements in combination with the standard enteral feeding solution will make you successful at achieving that. If the enteral route's not working, obviously the parenteral route is a strategy, and I'm just highlighting this work that we did with the top-up study where we're looking at caloric and protein adequacy in that first week, either by EN alone or by the supplemented route. And so we endorse this, particularly if you have a high nitrogen containing parenteral solution, then the combination of some low dose enteral, high nitrogen containing PN will also make you successful at achieving that high group. And last but not least, increasingly, people are using simple intravenous amino acids and enteral nutrition. So not combined supplemental EN and PN, but just the amino acid component of the parenteral strategy in combination with enteral, as was done in the NephroProtect trial by Gordon Doig. And yeah, we could say how this trial was negative, but at least it demonstrated the safety of this approach. And we're using the same approach in the Nexus trial, which is a trial of combined nutrition and exercise in critically ill patients. And so it's just another tool in our toolkit to achieve the high protein amino acid intake, particularly when the enteral route is not being successful. So again, just to stress that we're not protocolizing any of those approaches. I just reviewed them briefly to help you think through your approach locally as to how I'm going to achieve those high protein targets in the high group. So let's shift gears a little bit. Again, I'll stop for questions in a few more slides before I transition over to Jennifer, who's going to talk about some more operational details. But I wanted to review with you the study population. I think one of the biggest challenges in the critical care nutrition literature is that historically we tend to think that all ICU patients are the same and that will respond the same to our nutritional interventions, and thus we have a very open enrollment policy in these large-scale RCTs, and quite disappointingly, we see no treatment effect. And that's probably because of this heterogeneity of treatment effect, that there, people in the ICU will not all respond the same to augmented nutrition delivery. And so this is one of the first trials that really focuses on what we call nutritionally high risk ICU patients. And if any of you have know anything about the Nutrix score that we've developed, ideally I would have had that as the #1 enrollment criteria. You have to have a Nutrix score of more than 5 or more. But we've listened to many dietitians who have explained, not to be confused with complained, and that was a bit of humor, by the way. But anyway, have explained that it takes quite a bit of time to collect both the SOFA score and the Apache score, which are key components to the Nutrix score. And if we're expecting dietitians to enroll these patients prospectively as a part of their regular workload, that might be a bit too onerous. So in fact, we are not including the Nutrix score as a enrollment or an entry criteria. You will, after the fact or retrospectively, collect all these data points to support a subgroup analysis by Nutrix score. So that Apache score and that SOFA score eventually need to be inputted into the data set so that we can calculate the Nutrix score. It's just not done prospectively at the point of enrollment, but rather we rely on other criteria listed on this slide to define what we mean by high nutritional risk. And the color coding here is significant in the sense that things in green have a higher level of evidence supporting this identifies patients with nutritional risk, versus down below, things in red perhaps are a bit more of a hypothesis generating idea. Patients on the extremes of BMI, low BMI of less than 25, high greater than 35, we've seen people in the middle range not have any response to artificial nutrition, and so we're excluding patients with a BMI between 25 and 35. That's a really easy enrollment criteria. If someone's got a low BMI or a high BMI, then they're eligible for this trial, or they meet the nutritional risk eligibility criteria for this trial. And you don't even have to do any of the other ones prospectively. But if they're in the mid-range BMI, they can still come into the trial if they have one of the remaining enrollment criteria: moderate to severe malnutrition as diagnosed by local standards, and I'll speak more about that in a minute. A frailty as defined by a clinical frailty score of 5 or more, and I'll speak more about that in a second as well. Sarcopenia as defined by a SARC-F score of 4 or more, and I'll say more about that in a subsequent slide. And then finally, any ICU patient who has a projected duration of mechanical ventilation of more than 4 days. So long stay ICU patients, regardless as to their BMI, regardless as to their pre-existing malnutritional status, are what we consider to be nutritionally high risk. So say a traumatic brain injury who's comatose with severe brain injury, intubated, ventilated, lying on their back, they're at high risk and could be included. So let me just say a few more words about these inclusion criteria just to explain them. This is the data collection form that we use in REDCap to capture the nutrition diagnosis of moderate to severe malnutrition. We don't recommend an MNA or an SGA or an ABC or whatever tool you may, or a MUST or a MST, whatever you're using locally. We don't, that's fine, whatever you're using locally to define moderate to severe malnutrition. All we ask is that you capture the components of that tool and indicate them here on this data collection sheet. And at the bottom, if we haven't identified a particular component in that other, please specify. You can write that in and give us that information. So again, it's not protocolized the means by which you diagnose moderate to severe malnutrition. We accept whatever standard you're using currently. We're just trying to collect the components of them that will help us understand how you came up with that diagnosis. I refer to this slide, some of our early work where we used CT scans done for clinical reasons in patients admitted to the ICU, and showed that patients with low muscularity, as judged by these CT scans, had worse clinical outcomes than those that did not have low muscularity. And so we think that low muscularity is a risk factor, that it's important prognostically, that patients who have low muscularity have worse outcomes, but we struggle with how best to define that. I know Danny and other people are really interested in ultrasound as a way of perhaps as a surrogate measure for low muscularity, but perhaps that hasn't quite reached prime time. And so we're going to use a questionnaire that's been validated in the community setting, with an awareness that it perhaps hasn't been validated in this setting, but nevertheless, I think it'll help us bucket patients into people who have low muscularity versus those that don't. And if you look at the questions in the SARC-F scale, you really get a sense that it's really part of a good nutritional assessment where we're trying to understand the functional capacity of our patient. I think it's super helpful knowing what their functional capacity was prior to the ICU, because we're applying our nutrition therapies with a goal to trying to restore that function. So doing that as part of your baseline nutritional assessment seems to make sense to me. So it's a brief questionnaire that we use a proxy or a family member to help us answer those questions. And if they have 4 or more, then they're eligible to come in on the basis of low muscularity. Like I said earlier, if they qualify on some other criteria, like a low BMI, you don't have necessarily to do this at baseline or at pre-randomization. We are asking that all patients have a SARC-F score inputted into the data set. So at some point, when you have a moment, when the family's available, you'll ask them these questions so that you can score them. The only need to score them pre-randomization is when they don't meet any other inclusion criteria and you have a clinical suspicion that they have low muscularity based on their physical exam, or maybe they had a CAT scan that gave that indication. So you're going to dig up the family to try and get this question answered pre-randomization. Here's a recent paper that really supports this hypothesis that low muscularity or sarcopenic patients will have a better outcome in response to nutrition. This is a Japanese study where, again, they used CT scans to categorize people as non-sarcopenic versus sarcopenic. And then they looked at early versus delayed feeding in 254 septic patients. And in table 2, you see the crude mortality rates, and the benefit of early enteral feeding was very great in the sarcopenic group, where maybe not so much of a difference in the non-sarcopenic group. And table 3 is just showing the results of a regression model where, again, in the sarcopenic patients is where we see the benefit, the protective benefit of early versus delayed enteral feeding. So it supports this assertion that sarcopenic patients may have a differential effect and a beneficial, more beneficial effect from our aggressive nutrition therapies than patients who are not sarcopenic. So this will be an important subgroup analysis for us, and that's why we require all patients to have this metric done. And obviously prior to randomization if you need it as an inclusion criteria, post-randomization if you don't. This slide just reminds us of that relationship between sarcopenia and frailty. Sarcopenia as defined by the rectus femoris cross-sectional area and the frailty index. So the greater the cross-sectional area, the lower the frailty index. However, it's not a one-to-one relationship. And so in addition to low muscularity, we're asking to codify patients based on the clinical frailty scale, which again is a very brief, less than 2-minute questionnaire that we administer to a proxy, typically a family member who has knowledge about the patient's status. It's very visual, and so you instruct the patient to you construct the respondent, who's usually a family member, to consider the patient's condition in the 2 weeks prior to admission to hospital. And they glance at the visual cue on the left-hand side of that scale. They find the visual image that best reflects what they think the function of their patient is. They read that text. And if there's any uncertainty, we encourage them to read the line above and the line below before settling in on, okay, yeah, my patient was category 4 or whatever. And so this scale will also, we'll do a subgroup analysis based on the presence of frailty. Frailty being defined in this scale as a score of 5 or more. So that too is an inclusion criteria, and as I just mentioned, is also an important subgroup analysis. So this slide summarizes all the inclusion-exclusion criteria for this trial. You must be an adult, 18 years of age, who have at least one of those nutrition risk criteria that I identified. You can have more, obviously, but at least one. And you must have be mechanically ventilated for at least 48 hours or more from the point of randomization. Because what we don't want is, people to be randomized, set up on your nutrition prescriptions, and then the next day they're either extubated and transferred out, or the next day they die. The longer staying patients, the longer they have exposure to the different protein doses, the greater that patient will help us answer the study question. But we do have a few exclusion criteria. In the spirit of trying to be pragmatic, we've tried to really limit these. And number one is if you've been ventilated for more than 96 hours. And what we're saying there is, more than 96 hours, well, you've probably already had more than 2 to 3 days of nutrition at some dose. And so it could be contaminating, like say you were going to be randomized to the usual care dose, but you already had 2 or 3 days of high dose, or vice versa. So we kind of want to catch people as soon as possible, within 24, 48, ideally before, less than 72 hours. But we give you a 96-hour window, acknowledging that on some weekends there may not be adequate coverage to enroll a potentially eligible patient. So the point being, enroll as soon as possible. So you could have started the enteral, or the nutrition could have started as per clinical routine before you actually randomize them, but we don't want 96 hours to lapse before you randomize them. And we use mechanical ventilation as the start of the clock, because some patients, and not admission to ICU, because you know how some patients come down to ICU not ventilated, they're monitored for a day or two, and then maybe they get intubated, a day later or 2 days later. So 96 hours of mechanical ventilation. But yeah, if somebody's been non-ventilated for a week in your ICU and then gets ventilated, that patient group is different or heterogeneous compared to, this early enteral feeding paradigm we're working with. And so we'd ask you not to enroll those patients. If a patient's not going to survive or not expected to survive, or typically an older patient where there's a question of their goals of care, and there may be a conversation about removing or limiting their life-sustaining treatments within the first 7 days of screening, don't enroll those patients either. Again, I already said that the longer the patient stays alive and being exposed to nutrition, that's the better patient that we want in this trial. I know that some of your randomized patients will die, or some of them will unexpectedly get extubated and discharged. And that's, once they're randomized, they're in the trial. So even if they have a short exposure, we'll live with it. That's why we have 4,000 patients, or we aim to enroll 4,000 patients, because some of those patients will be noise or non-contributing patients, but hopefully we'll have enough that help us see that signal. Pregnant patients are excluded because of the unknown effects on the fetus. Number 4, this is where we've experienced the biggest problem so far in operationalizing this study at various sites, is that although at a site level you agree that there's equipoise and you want to be involved in this trial, at an individual patient level, people say, oh, patient has a high BMI. Oh, the guidelines, American guidelines, say that, oh, we should be prescribing high dose protein to these obese patients. And so they exclude these patients because they feel like there isn't clinical equipoise, there isn't uncertainty about what the right answer is. And I push back and I argue that even though there may be these best practice statements that come out as clinical guidelines, there's no RCT level of evidence to support them. Or in particular with the obesity guidelines, there's 2 RCTs totaling 46 hospitalized patients, 13 of which were ICU patients, and the primary outcome was nitrogen balance. So if the hypothesis is that extra protein amino acid impairs autophagy and is associated with worse muscle function and worse clinical outcomes, then 13 ICU obese patients randomized in a trial looking at nitrogen balance does not convince me or any evidence-based practitioner that there is sufficient evidence in obese patients that we should be prescribing a high dose. And so we try and communicate that rather than exclude them, include them, and we'll have a nice subgroup analysis, which will be the largest RCT in those obese patients to figure out, does a high protein dose really matter? The last exclusion criteria pertains strictly to patients who are PN dependent. And if you don't have a high nitrogen containing PN solution, you may be unsuccessful at getting that high protein dose in. And so we'd ask you just not to enroll those PN patients if you don't have the right products. So I kind of touched on this already, where we get questions about various subgroups or different case mix groups within the heterogeneous ICU patient population, where a practitioner says, hey, what about renal replacement therapy? Don't I have to give high dose protein to all patients because of the losses? Or, hey, what about burns or surgery or trauma? Aren't we supposed to give high dose? I'm not comfortable randomizing them to a low dose. And it's the same answer that I gave before, that there is no RCT level of evidence to support this assertion. And if you're monitoring the evolution of the literature, there are these signals that protein administration is harmful. And so how do we know? Just based on a story of losses, doesn't seem like it's sufficient evidence to know what the best idea is. And so again, we'd rather have these patients enrolled in this trial. And a priori, we specified several subgroup analyses that we, amongst the 4,000 patients, let's say we have, 400 trauma patients. And so again, that'll be the largest trauma randomized trial evaluating protein dose. So I'd rather have these patients included and then excluded because of lack of equipoise. Having said all that, there may be exceptional patients, and I'll give you an example of a patient with severe burns who also had an intestinal injury, required laparotomy, was packed open, had a lot of fluid losses, developed renal failure on renal replacement therapy. And so, with such high catabolism and protein losses, maybe on that patient, I wouldn't include them, and I'd dose them with some high dose protein. But I use that as an exceptional case. It shouldn't be the rule that burn patients, for example, or patients with RRT, for example, get excluded, but rather we want them included. For those of you who have participated in the International Nutrition Survey in the past, the data we collect will be very similar to what we've done in the past, except we've streamlined it a little bit. We used to collect a lot of data on glutamine or selenium or probiotic supplementation, and no, we're not collecting that anymore. Trying to simplify the data set that will be relevant to answering this study question. I've highlighted in red that we are collecting a few extra data points that I've already mentioned, the frailty scale, the SARC-F scale. And then in general, we're collecting data to describe the patients, to describe your nutritional assessment, the nutritional processes of care that they received, and then the outcomes. Again, these are all outcomes that you abstract from a chart at the end of the stay. These are the same outcomes that we've been collecting for years, with the exception of we have added PODS, or persistent organ dysfunction, where we're looking for the use of vasopressors and renal replacement therapy and ventilation, but we've always been capturing duration of mechanical ventilation. That's just a novel outcome that we've developed that we think will be helpful in telling this protein story. So all of these are things that we can extract from a chart. So at this point, I'm going to pause. That ends my presentation and my explication of the patients, the intervention, and the outcomes. May I hear about any questions that you might have on anything I said? And then after we're done the question and answers, I'll turn the time over to Jennifer to explain a little bit more about the logistics. Please, questions.
Darren, it's Louise from Yeovil. Hello.
Hi.
Can you hear me okay? I just noticed in the specific data points, there's also a left calf or right calf measurement. Is that obligatory, or is that just an additional data point you would like?
Yeah, I would say that's optional. It comes from our Asian colleagues who are trying to validate that as a marker similar to low muscularity, sort of a surrogate for low muscularity. And so we include it in the data set, and to the extent that it's easy and you'd like to, go for it. To the extent that you can't or it's not able to, it's optional.
Okay, thank you. And now there are a couple of small questions. The other one is triglycerides is something that we don't do daily at the moment, but it's a daily data point. Is that also something that you would preferably have done in the blood?
Now, with the blood work, so thank you for that question. With the blood work, we're not protocolizing anything, but we are enabling you to enter, triglycerides, urea, renal function, liver function, blah, 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 but only when it's measured for clinical reasons. So whilst there is a daily field open for you, we don't expect you to, put a data point in there every day. It's only when you do it for clinical reasons, then record it in our data set.
Okay, fabulous. So we won't be doing the PN, so that might not be relevant for us particularly. But the other last question I have is your target, the goal that you're setting. How soon to reach that goal? Say a patient's randomized on day 2 of 1 to 2 of ICU, and you set the goal as a dietitian there, and I particularly have refeeding patients in mind.
Yeah. So again, that's a great question, and obviously you're going to, want to manage those refeeding patients, a little bit differently than the average patient. You do what's clinically sensible, from your point of view. Again, this is a pragmatic trial. We express the targets achieved cumulatively. So over the entire stay, did the patient get, 2.2 or 1.2, as the case may be. Obviously, if you have a pause for many days at the early phase, you're going to struggle to hit that cumulative metric. So in general, our general advice is to try and achieve those metrics, within 2 to 3 days of randomization. But there may be exceptional reasons why you can't or you shouldn't, and we live with that.
Great, thank you.
Great questions. There's another question about protein requirements with oral nutritional supplements once the patient is extubated and safe to eat and drink. You may, for clinical reasons, track protein intake via the oral route, but we don't. We don't ask for it. In fact, our nutritional adequacy calculations end when the patient transitions to oral nutrition supplements. But I would strongly encourage you, for clinical reasons, to use oral nutrition supplements, high protein containing oral nutrition supplements, track them if you like. But just because of the lack of accuracy or lack of validity in those measurements, we don't capture that in this trial. Other questions, please?
Hi there, Darren. Just got a question. It's Sarah here from East Lancs. The SARC-F scoring, quite often our conundrum is the reality versus what actually the relatives tell you. Will there be the option to go back in and correct a SARC-F score later on if further information comes to light?
Jen, correct me if I'm wrong, but I believe your case report form, which Jen will explain REDCap and how that works, is open and correctable until the end of that patient's stay when we close it and lock it. So the answer to your question is yes.